Good morning, everyone. Today we do shock syndromes. The objectives for class today are identify the types of shock syndromes. There are 3 types of shock syndromes, and we'll go through each type of those. We'll explain the causes of each type of the shock syndromes. Hopefully by the end of the core class today, you'll recognize what the hemodynamic changes are as they are associated with each type of shock syndrome. And then finally, you'll list the assessments and treatment for each type of shock syndrome. I've listed a couple of websites here just as additional resources. The Prezi is actually really good. We're not going to take time to look at it right now, but it is a really good resource for you, as well as the website above that. So if you have time, take a look at those things. So what is shock syndrome? You've probably heard people say, oh, they had a traumatic event in their life and they just went into shock, which can be true, but there is a physiological reason why people have shock syndromes. A general definition of shock is a condition in which the cardiovascular system fails to perfuse tissues adequately. And this can be caused by 3 things: a cardiac pump impairment, a circulatory system problem, and or a volume problem. So we'll look at those 3 types of shock syndromes as we move through this. First, I want to talk about the general response. Typically, you have inadequate tissue perfusion. That's your first thing that happens in the cascade of events in the shock syndrome. So when this happens, you have generalized cellular hypoxia, you have widespread impairment of the cellular metabolism, you have tissue damage, organ failure, and then impending death if it's not treated immediately. So diagnosis can be made by clinical signs and symptoms. What do you think the signs and symptoms of hypoperfusion are? Right, I heard somebody say cool and clammy skin. Yes. Let's start at the head and work down. What's going to happen in your brain? Or how might you notice they have hypoperfusion in the brain? Yes, altered mental status changes, changes of consciousness, things like that. As you work your way down to the heart, you may have a high heart rate to try to compensate for the lack of perfusion. You may have a high respiratory rate, the body's way of trying to get more oxygen to the body. Cardiovascular perfusion will decrease. You will see that in capillary refill, you'll see it in blood pressure, all of those things. And then finally, you'll see a decrease in urinary output. The kidneys fail to get perfusion, so then they quit making urine. So that might be one of your signs and symptoms as well. Okay, so the pathophysiology or the pathology of shock is impaired tissue perfusion that occurs when an imbalance of cellular O2 supply and O2 demand are not meeting each other's needs. So the cells, if they're not getting enough oxygen, they switch to anaerobic metabolism, which causes a huge amount of lactic acid production, which we talked about when we talked about sepsis earlier in the quarter. You will see cell function cease and the cells swell, which causes a membrane around the cell to be more permeable, which throws off that sodium and potassium pump. Then you'll see mitochondria damage, which can result in cell death, which then the tissues can't absorb any of the oxygen. This is a nice cascade is what they call it. It's the path of what happens when you start out with inadequate perfusion. So you can take a look at that and notice that the end point is destruction, dysfunction, and cell death. One of the pieces that happens here is you have the SNS and adrenal response. You have compensatory mechanisms. Your baroreceptors are stimulated, which causes the increased heart rate, like we talked about earlier, which in turn causes increased contractility, some vasoconstriction, an increase in preload, and decrease in renal perfusion. And these next couple of cells just go through what happens in all of that. So you have path of decreased renal perfusion, which leads to potent vasoconstrictors being released. Remember, we talked about vasopressin being normally produced in the body when we did ACLS. You can give it externally as a medication for blood pressure, but know that your body also produces it. And this is one thing that happens when the baroreceptors are stimulated from a decrease in blood pressure. Then the vasopressin is released, causing a short-term increase in blood pressure. And the next picture shows renal and angiotensin release, and finally this circle graph shows what happens. It's a vicious circle. You have renal sodium and fluid retention down in the right corner, which leads to increased blood volume, which can cause some systemic vasoconstriction, because the body doesn't know what to do with all that blood that's being produced as all these chemical and hormonal changes are happening, which can overload the heart system or the vascular system, and it's a vicious circle. So it tries to keep the blood to the core, which the end result is not getting blood to the kidneys, where it decreases your urine production, which stimulates your baroreceptors, and on and on and on it goes in a vicious circle. This is just another explanation of what happens when your adrenal gland is stimulated. It releases steroids, which messes with your blood sugars. And that, remember, we talked about blood sugar control when we talked about sepsis. So this is one of the reasons why that happens. So let's talk about the stages of shock. You have the initial stage where the tissues are underperfused, you have cardiac output decreases, you have an increase in anaerobic metabolism, and you have lactic acid building up in the cells. This is a reversible stage. If you catch it in this stage, shock can be reversed. As well as when you have the compensatory stage, it is also reversible. Your body's attempting to compensate for that decreased tissue perfusion. You have what's known as the progressive stage next, where your compensatory mechanisms are starting to fail. This could lead to death if you have a frail elderly person who has little reserve, or it can be reversible if you have a normally healthy person that just maybe had an MI, maybe was ill, maybe had a trauma, whatever, but this can be reversible depending on your body type. The next stage is irreversible or refractory stage. This stage, it doesn't matter what your body type was before. If it gets to this stage, death is pending. Before that, you will have multiple organ dysfunction syndrome. You have cellular necrosis, decreased myocardial contractility, decreased vascular tone, and your whole body is just shutting down, and this is where death is imminent. So as I mentioned in the first slide of our objectives, you have three types of shock. You have a volume problem, which is hypovolemic shock, which is a preload problem. You have cardiogenic shock, which is a blood pump problem and a contractility problem. Your left ventricle just isn't pumping like it should. And then finally, you have a distributive type shock, which includes septic, anaphylactic, and neurogenic shock. And this type is a blood vessel problem, or otherwise known as an afterload problem. So let's start. Oh, I forgot to change slides here. Hang on just a second. Okay, so there's your three types of shock. Are going to be helpful as we move through the slides. It has the hemodynamics of each type of shock syndrome. So I will refer you back to these. I put them at the beginning of the three types of shock so that you could refer back to them. All right, let's start with hypovolemic shock. This is an empty tank syndrome where you have decreased tissue perfusion due to loss of volume in the body. Okay, again, you have that general shock response where you have decreased venous return. You just don't have the body fluids in your system to help with ventricular filling. That leads to decreased stroke volume, leads to a decreased cardiac output, leads to inadequate tissue perfusion. You can have an internal fluid loss. Say you rupture your aorta and the blood is actually in there. It's just not in the vasculature pumping through your vessels like it should. You can also have an external fluid loss. Maybe your arm gets cut off and you have blood squirting out, or your femoral artery is punctured, or whatever. You can see that noticeable blood loss. The other type of blood or of fluid loss you can have is extreme dehydration. People that have been left out in the desert, people who have been vomiting for days on end, maybe they had an illness, whatever. But those are types of hypovolemic shocks, or types of causes that can lead to hypovolemic shock. How to assess these patients? How do you know how severe it is? What are things you're going to be looking at? Let's start at the head again. Decreased level of consciousness, high heart rate because the body's trying to compensate for it, hypoxia, high respiratory rate, and then decreased blood pressure, and then decreased urinary output. Your body can actually compensate for a loss of fluids up to 15%. Your body can overcome that pretty easily. The 15 to 30% range, you're going to start to see more hypoxemia, decreased blood pressure, and urinary output. 30 to 40% loss is impaired compensation. Your compensatory mechanisms just can't work that well to keep up with that, and you have profound shock along with severe acidosis because apparently evidently your lactic acid is going to kick in because of loss of oxygen to your tissues, so you'll have that lactic acid production. Next, you'll have the 40 to 50% loss, which is refractory stage. At this stage, unless you can immediately treat them, this would be like the severe traumas or the ruptured aortas, and maybe they can't get to the hospital quick enough, or maybe you don't recognize there's a problem quick enough. This stage is typically fatal to a patient. How are your patients going to look when they are severely hypovolemic? Are their breath sounds going to change? No, probably not. Probably no change there. What about urinary output? Diminished, right? Decreased blood pressure, decreased urinary output, decreased level of consciousness. Heart sounds typically won't change in this one. And then the rest of your hemodynamic parameters, I will refer you back to those tables at the beginning of the presentation. So your main goal for hypovolemic patients is to restore volume as soon as possible. You need to correct the problem. Do they need to go to surgery? Do they need blood pressure products? Do they need blood products themselves? Do they need medications? What exactly do they need? So you need to fix the problem immediately. Any questions on hypovolemic shock? All right, let's move on to cardiogenic shock. This is where the pump is unable to pump. The left ventricle cannot pump the blood out to the aorta. Like I talked about earlier, typically is caused by a left ventricle myocardial infarction. The left ventricle is damaged. I have seen patients where their papillary muscles have ruptured, or they've had a ventricular aneurysm, they have a septal rupture, something like that where the blood just cannot pump. You might have a cardiomyopathy where the blood or the heart just gets big and floppy and is unable to pump. This would be a chronic condition and not necessarily an acute condition. Cardiac tamponade and tension pneumothorax can occur when a trauma happens, or they get fluid around the heart, or they have air in their lung that can't escape, and it compresses the heart enough where the left ventricle is unable to pump. And then there's arrhythmias and valvular diseases. Usually when 40% of the ventricular mass is damaged is when you'll see patients go into cardiogenic shock. That's just a rule of thumb. Okay, so again, they're going to have that general shock response. They're going to have inadequate systolic emptying. They're going to have decreased left ventricle filling pressures, which leads to decreased left atrial pressures. And then what happens here is they have an increased pulmonary capillary wedge pressure because that blood is sitting in the left ventricle. There's nothing wrong with the right side of the heart. It makes it to the right side of the heart, but your left ventricle is unable to pump it out. So it backs up into the left side of the heart. And again, you have some vascular changes with this, with the chemical changes that are happening, which can lead to increased permeability, which can lead to pulmonary edema. So this would be cardiogenic pulmonary edema from all the pressures that are or all the problems that are happening and the chemical changes that are happening. Typically with the pulmonary capillary wedge pressure, you've read in your book when we talked about CHF and ARDS. With this, it's cardiogenic pulmonary edema, so their wedge pressure is going to be greater than 18. That's a good thing for you to know and keep in mind. Hint, hint. Okay, so what are these people going to look like and feel like and sound like? You can work through that in your head. Give you a minute here. What are they going to sound like if they're in pulmonary edema? Right, crackles throughout all lung fields. You'll hear a loud murmur, especially the S3 sound, that whooshing of the blood in there. Increased respiratory rate, decreased urinary production, decreased level of consciousness, and then you can get your hemodynamics off the tables as mentioned before. So how are you going to fix these patients? What are some things you can do? You're going to treat the reversible causes. If they have a pneumo, you're going to fix that. If they have cardiac tamponade, you're going to fix that. What if they have an MI? You'll probably want to get them to cath lab, get that vessel reopened so they don't have too much tissue necrosis to their heart muscle. You might need some thrombolytics. You need to increase their pumping action. Maybe they need inotropic drugs. Maybe they need vasoactive drugs. Maybe they need a little bit of fluid backup, things like that. But you really want to restore their pumping action. Okay? How are they going to feel? Are they going to be comfortable laying there in their bed? No, you're going to maybe give them some morphine, which will help decrease their anxiety as well as decrease their preload. Remember, we talked about preload in morphine and its effects when we talked about ACLS. So you may be able to give them a little bit of morphine, get them to cath lab, get their heart restored. All right, any questions on cardiogenic shock? All right, let's move on to distributive shock. Distributive shock is where the pump and the volume are working just fine, but the blood is not reaching the tissues because this is a vessel problem. You have ineffective vessel tone with the distributive type shocks. So your pump is fine, your blood volume is fine, but you have a vessel problem here. Most commonly caused by septic shock, and then less commonly caused by anaphylactic or neurogenic shock. So let's start out with anaphylactic shock. What do you know about anaphylactic shock? What's it caused by? Yes, an allergic reaction. Yep. So bee stings, food allergies, blood product allergies, any of those types of things are going to cause an anaphylactic shock. So what happens here is they have a massive vasodilation because of all the antigens in the body. You have a huge amount of inflammatory mediators that are released to get to the site of the antigen. You have increased vascular permeability, so they could go into pulmonary edema pretty quickly because you have that permeability again. What are some other things that might happen? Has anyone seen anybody get a bee sting and they have an immediate reaction? Right, they might bronchospasm. What might you hear with the bronchospasm? Good wheezes, cough. They might have increased mucus production. Good, all of those things. So like I said, they're going to have massive vasodilation, so their blood pressure is going to drop. They might have hives. If we're talking about skin a visual of their skin and overall appearance. They might have hives. Another word for hives, just FYI, is urticaria. You hear some physicians say urticaria instead of hives. They might also have a condition called angioedema. That's swelling beneath the skin rather than on the surface. So you might see some angioedema with these patients. Typically, the anaphylactic shock is an immediate response. They might have stridor, wheezing, increased mucus production. Respiratory distress is pretty common with anaphylactic shock, so you have to be prepared to intubate them, give them whatever meds they need. They might need steroids. I'm going to flip this slide here. They might need steroids, they might need IV epi, they might need an EpiPen, they might need antihistamines, but you need to withdraw that antigen as quickly as you can. So if it's a bee sting, you need to get the stinger out of there. If it's peanuts, you might have to give them fluids to get it out of their system. If it's medications, again, you might have to give them more fluids to just wash that all away. So the main thing is early recognition and be aggressive. These patients respiratory fail rather quickly, so you really need to recognize what's going on with this. All right, the next type of shock we're going to look at is neurogenic shock. There really isn't a ton of information on this, except that it happens when the patient loses or has a suppressed sympathetic tone. So their sympathetic nervous system has been shocked or traumatized, and typically it's from spinal cord injuries above your thoracic 6 level. So about the level of the carina and higher is where this injury can cause some neurogenic shock. And what happens is the brain loses connection to the heart and to the rest of the vital organs. This is called autonomic dysreflexia as well. You might hear neurogenic shock called autonomic dysreflexia. Thankfully, it's rare and you don't see it very often, but it can happen. Their clinical presentation, really you can look at your chart to find out the hemodynamics, but really their heart rate will probably drop and their blood pressure will drop, but the rest of the things will be normal. All right, let's move on to septic shock. Caused by what? What do you usually see septic shock caused by? Yes, an overwhelming infection that doesn't get treated. So you can have sepsis and it's treated and it doesn't get into septic shock. So don't think that all sepsis patients are going to go into shock. How do we know if they're in shock? Remind me what the definition of shock is. Yes, hypoperfusion. So if you see a septic patient showing signs of hypoperfusion, you know they are in shock. Prevention is first and foremost. You want to make sure to get the antibiotics started immediately. They're kind of using a new triple cocktail, they call it, the Levaquin, Zosyn, and vancomycin antibiotics. They used to use Zygris, and you see that on that rap video, but the Zygris is causing more problems than originally thought. It's causing a heparin-induced thrombocytopenia. So you still might see it, but it's not being used as much as it has in the past. You want to prevent the injury in the first place, I guess would be the best thing to do, but you want to recognize it and treat it immediately. Fluids, repositioning the patient, things like that are basically what are going to help fix a neurogenic shock. But again, there's not a lot you can do. There's no meds to give them. There's no antibiotics. You may have to give them some atropine if their heart rate does drop from the autonomic dysreflexia. But other than that, you just have to watch them and hope that it gets better. All right, what happens with septic shock, you're going to have 2 phases, and I want you to write this down. With the warm phase, you're going to have massive vasodilation with a massive increase in your cardiac output. So you have all these chemical changes that are happening. You have receptors that are being stimulated, and you're having a massive vasodilation, increase in cardiac output in the warm phase, as well as a decrease in blood pressure and an increase in SVO2. Because you have so much vasodilation happening, your SVO2 is delivering the blood, but the tissues aren't being able to absorb it. Okay, so it's not being dropped off at the tissue site, because remember, we're having a vessel problem. So in the warm phase, I want you to write this down: decreased blood pressure, increased cardiac output, and increased SVO2. If you see a patient with an SVO2 in the 80 to 90% range, you can suspect sepsis, septic shock. Okay, so that is the warm stage of septic shock: massive vasodilation, decreased blood pressure, increased cardiac output, and increased SVO2. Those are your 3 hallmark signs of septic shock. When it gets to the cold phase, you're going to have decreased blood pressure again, but now you'll see the decrease in cardiac output and the decrease in SVO2. So write those 3 things down. With the cold phase, you'll have decreased blood pressure, decreased cardiac output, and decreased SVO2. Like your SVO2 might be in the 30 to 40% range now in the cold stages. That is impending multi-organ system failure and probably impending death at this point. Okay, any questions over 3 types of shock that we talked about? Remember, we talked about a vessel problem, which is distributive, the pump problem, which is a cardiogenic shock, and the volume problem, which is the hypovolemic shock. So know those 3 types of shock, what causes each one, the clinical presentation of each, and the management and treatment of each.